Welcome to Approach to the Patient with Heart Murmur. So, a few learning outcomes that are reviewed otherwise in the actual Med Guide article. So let's begin with basic science. So, just to remind you, Anatomy 101, the flow of blood through the heart. So let's pause this GIF here. So, in through the cable veins, then you have the right atrium, and then the tricuspid valve guards the right ventricle contracts, and the pulmonary trunk receives this blood supply to go to the left and right pulmonary arteries for the pulmonary capillaries to be perfused. Pulmonary veins return oxygenated blood to the left atrium, and then the mitral or bicuspid valve guards this flow as the right ventricle with the apex throws it into the aorta, like so. And if we look at this lovely animation here, we can see this is the tricuspid valve, this is the bicuspid or mitral valve. These are the chorda tendini that are holding the valve in place. These are papillary muscles that hold the chorda tendini in place. Here is our pulmonary valve, and the aortic valve from the left ventricle is under here, so we can't quite see it because of the interventricular septum and the outflow of the right ventricle here. There's our auricle, there's our cava, superior vena cava, inferior will be down here. So, I want to talk briefly, a quick reminder of the heart valve sounds. So, lub-dub, S1, S2, respectively. So, lub is the closure of those AV valves, your tricuspid and your bicuspid valve, and S2 is the closure of the semilunar valves, your aortic or your pulmonary valves. These are the two things that happen with valve pathology. We have stenosis and we have regurgitation. So what's going on there? Well, in a nutshell, stenosis is a narrowing and regurgitation is where those valves are no longer useful. So they blow open. So they're permitting flow to be where it shouldn't go. So we can say that anterograde flow is restricted in stenosis. You can't get through the hole. Whereas in regurgitation, retrograde flow is permitted. So in both cases, blood is not going where we want it to go. Now, because the overriding function of the heart is to get useful blood to the brain and the viscera, and to accept less useful blood and get it to the lungs to become more useful blood, if we have an issue with the transport of blood, so anterograde flow is restricted or retrograde flow is permitted, the patient's going to get quite sick quite quickly. There is a response called hypertrophy in stenosis. So if this is my aortic valve and it's stenosed, the left atrium lets the blood come through to the left ventricle, and the left ventricle has to push extra hard to get through this stiffened valve. This could be calcified, it could be damaged because of an infection or an inflammatory process, and that means that this hole that should be as wide as this lumen here is only this wide. So the hypertrophied left ventricle pushing against this structure here. In contrast, regurgitation causes dilation, what we call eccentric hypertrophy, as opposed to concentric hypertrophy, which is stenosis. So here's our left atrium, it supplies the left ventricle, but then if we have a regurgitant mitral valve here, then the blood will flow back into these structures. And this is actually giving an aortic regurgitation example, where the blood is going up from the left atrium into the aorta, and then because this valve can't close, it regurgitates retrograde back through. If this were a mitral regurgitation, it would go through the left ventricle, out into the aorta, and out into the left atrium. So, I've mentioned S1, S2. Let's add another layer of complexity to the mix here. S3 and S4. So between S1 and S2 is systole. Everything outside of S1 and S2 is diastole. Okay, so S3 and S4, by definition, have to be diastolic sounds. Okay, so lub, dub, and you can think of S3 and S4 as sounding like the word tar. So if we have an S3 sound, it will sound like this. Lub, dub, tar. If we have an S4 sound, it will sound tar, lub, dub, like that. So we have the closure of the AV valves, closure of the semilunar valves, and then S3 here is an overfilling noise from dilation. So a regurgitation has occurred, we have a dilation of the vessels, or we have a dilatory cardiomyopathy, and the result is that there's this eccentric hypertrophy, and there's an overfilling going on. So that's the S3 noise that you hear. And then S4 is spitting against a hypertrophic, concentrically hypertrophied wall. So go away and review your basic science if that doesn't make much sense for you. And we will push on with the clinical now. So I want to talk about valvular disease that you will have with you from cradle to the grave that isn't an acquired thing. Abraham Lincoln is believed to have had Marfan Syndrome, the famous Civil War president who ended up being shot in the head. So he wasn't killed by Marfan Syndrome, but Marfan Syndrome is a connective tissue disorder. And we've already mentioned these wonderful papillary muscles and then the chorda tendineae holding the valves in place. If you have a connective tissue disorder, then the valves and the papillary muscles, chorda tendineae here, are not going to be as useful as you'd want them to be. So these patients with any connective tissue disorder, Ehlers-Danlos syndrome, Marfan syndrome, they are predisposed to all kinds of valvular heart defects from cradle to grave. Another one is aortic valve stenosis. This can occur congenitally, although usually it doesn't, but it can occur congenitally. So you can have an aortic valve stenosis from birth. The acquired ones that we're going to talk about today basically split up into 4 different things. So we have rheumatic heart disease, infective endocarditis, the consequence of an infarction of the tissue, and senile degeneration. So if we begin with rheumatic heart disease, so the epidemiology of rheumatic heart disease tends to be a patient who's had a sore throat recently, or had it when they were a kid, had the fever, the scarlety fever kind of thing, and then progress in middle age to this thing called rheumatic heart disease. So it's a group A strep. That's the thing that causes it. Streptococcus group A. And it's the strep throat that you hear talked about. And what happens is actually antibodies that are caused in response that are secreted in reaction to the group A strep's antigen, the PAPs and all that things, the PAMPs and all those things, they cross-react, funnily enough, with the myocytes and with the endocardium of the heart valves and damage them and cause an endocarditis and inflammation, and this causes valvular defects. You're going to look at the Jones's major criteria. There's a minor criteria as well, but don't worry too much about that because it's kind of straightforward. It's like raised acute phase proteins, first degree heart block and things. But the major criteria are the ones you really need to know. The arthritis, carditis, erythema marginatum, which means a margin that is red. So these little rash-like looking things that just have a margin of red and the rest of the skin is clear. And then 2 S's, Sydenham's chorea, which is like the chorioathetosis St. Vitus dance that you see in Huntington's disease, but it's transient and it's after strep throat. So that's quite interesting. And then it self-resolves, or obviously it resolves with antibiotic therapy. And we can give something for that, which we'll discuss in a minute. And then subcutaneous nodules, so little bumps under the skin that don't have any particular colour because they're too far under the skin. So you're going to order an ECG and an echo. And the ECG is going to check for bundle branch blocks or AV blocks. This is because of that inflammatory response that could have damaged the heart, could have been damaged. It's a cross-reaction to the myocytes, and actually the conduction system, your AV bundle, your sinoatrial node, your His Purkinje conduction fibers are actually just modified cardiac myocytes, so they can still be hit. The echo is diagnostic for valvular defects, so you're going to do an echo, and that will be the case throughout this lecture. The management is what you'd expect, benzyl penicillin, and you might need to carry that up until the end of puberty because patients can recur and recur. Bed rest, because you want to decrease the work of this overtaxed heart. Steroids and aspirin for the inflammation. Try aspirin first if it's not contraindicated. And then the patient may need haloperidol for the chorea. So, infective endocarditis. So, the epidemiology of IE is males of all ages usually. And the etiology kind of depends on what's going on. So, strep viridians, or viridian streptococcus, is the most common across all, apart from if you have a prosthetic valve or you're an IVDU, an intravenous drug user, in which case Staph aureus is the most common. That will affect your treatment, obviously. You're going to use something called the modified Duke criteria, which if you're interested, look it up, but otherwise you'd probably just look it up on MD Calc, right, when you're seeing a patient with query IE. So shortness of breath and constitutional signs and a few others. But the key things that seem to be quite rare but come up routinely in medical school exams are the signs of microembolization. So you've damaged the heart valves here, and all the blood in your body has to pass through all 4 of those valves every few minutes, basically. And so in that case, if these valves are damaged, then Virchow's triad will occur. There'll be a stasis, turbulent flow, hypercoagulable states because of that, and it'll be throwing off mini clots. And these mini clots show up in 4 things characteristically: Janeway lesions, Osler nodes, Roth spots, which are little red spots in the eye on fundoscopy, and splinter hemorrhages. You're also looking at under the modified Droop criteria in addition to those and the constitutional signs for risk factor behaviours like intravenous drug user or patients with prosthetic valves. And you also will get points for a positive echo, which is actually your diagnostic test as ever. At the bedside, because you're looking for microembolisms and damage to end organs and things, urinalysis for hematuria, you're going to perform an echo and an ECG. And characteristically, the PR interval is prolonged in infective endocarditis. Bloods, full blood count, including acute phase proteins, white cell counts, and things like that, and MCS. And interestingly enough, you need 3 different samples, 1 hour apart, ideally from as many sites as you can get, from 3 different sites or 2 different sites, or if you have to, then the same site. But try to get different sites and spread them apart. Imaging, consider CT angiography, but the echo is diagnostic in most cases. For a native valve, you're going to treat the patient with amoxicillin and gentamicin, going after that strep viridians. If it's prosthetic, you're going to give Genta, but you're going to add Vanco and rifampicin. And you're going to do that to take care of some of the weird and wonderful things first line that could be causing it. Obviously, when cultures come back, tailor, but that's your empiric first line. So, the other 2 we were talking about etiology-wise is senile degeneration and post-MI infarct. So your senile degeneration is usually calcium deposition, and there are a few areas like your arachnoid granulations in your brain, well, in your brain case, and the xiphoid process that calcify with age. So do valves, classically the aortic valve. And these little nodules that you can see, this is calcified deposits there, which will make it harder to keep the valve closed, to open the valve, basically for the valve to do anything. The other thing that we need to make you aware of is a post-MI infarct. So here's your papillary muscle, here's your chorda tendini, and here is some of your mitral valve. And basically, if you have, classically it's an inferior MI, the consequence of that is actually quite severe, because if you have significant ischemia, it can damage the muscle and ruin the integrity of the papillary muscle and cause it to let go of the valve, and so it will regurgitate. So let's jump into left-sided disease, and we'll start with a condition called aortic stenosis. Now, the epidemiology of aortic stenosis is usually older people, and the etiology is calcium, senile degeneration, and rheumatic fever. So here's an ablated aortic valve that you can see, and you can see the calcium deposits there as they're having surgical aortic valve replacement. The history is a very characteristic one, and the mnemonic is SAD, S-A-D, syncope, angina, and dyspnea. And this is all related to aortic stenosis, which is decreasing the ability for your left ventricle to fill the aorta and thereby perfuse your organs. Syncope, because you're not getting enough blood to the brain. Angina, you're not getting enough blood to the coronary arteries. And dyspnea, because you're not getting enough blood anywhere. So, the exam, you're going to see a slow rising delayed pulse. And of course that makes sense, because it's going to take a lot longer in that cardiac cycle for you to push the blood through the smaller orifice. There's going to be a narrow pulse pressure between systolic and diastolic pressures, because your preload and afterload is changing based on cardiac output. You'll hear an S4 sound, which is the blood spurting at the end of diastole against the hypertrophied left ventricle. And because the left ventricle is so big, you might see a left ventricular or left axis deviation on ECG, and you might see a heaving apex when you feel that apex in the fifth intercostal space midclavicular line on the left-hand side. We describe the murmur as a crescendo decrescendo ejection systolic murmur that may or may not have the S4 sound, and it looks like this. So as S1, so the systole begins here, and as ejection starts to happen, hence ejection systolic, the blood rises up and up and up. It gets louder and louder and louder as the force is eventually pushing it through that narrow orifice, and then we run out of blood in the ventricle and it drops down, 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 down. So it looks like that, and it sounds like this. So it goes peak down, peak down, peak down. It's one sound. It's ejection systolic. It's throughout the systole period, and you cannot discern lub dub very well, can you? Because it's just one continuous sound that connects S1 and S2. So the labs that we'll see will be the classic threefold in valvular heart disease: an ECG, an echo, which is diagnostic, and a chest x-ray to look for any consequences like cardiomegaly, pulmonary edema, and the like. Here is an echo. Here's our left atrium, and here's our left ventricle. There's the interventricular septum. The apex will be down here. So here is our mitral valve, or our bicuspid valve, functioning normally and opening and allowing blood to come through. Here's our aortic valve. Look at the hole when it opens up. It's absolutely tiny, absolutely tiny. So that's a really severe aortic stenosis. And if you look here, you can see that there's some hyperfluorescent things here. This is probably calcium deposition that's causing that severe aortic stenosis. And it's an echocardiography like this that is diagnostic for the thing. So the management initially, conservatively, if you're not a cardiothoracic surgeon, is bridge to surgery. So you're going to do balloon diuretics, and if it's particularly bad, if the patient's particularly severe and they can't go straight for surgery, a balloon valvuloplasty, where they put their balloon in and they pump it up and they give it a bit of space, basically. The definitive treatment is surgical aortic valve replacement, or SAVR, which is your open heart surgery, and the more in vogue at the moment is your TAVI, transcatheter aortic valve insertion, where the valve is placed around a balloon, which is pumped up when it gets to that aortic orifice and leaves the valve within the stent, which stays up, basically. So you put the balloon, stent stays in place, and then the valve's within. That's what it looks like, basically. And that's TAVI. So pushing on, aortic regurgitation. So this is the opposite. Similar demographics, older people. But there are different findings whether it's acute or chronic. So the etiology for the acute aortic regurgitation is infective endocarditis. Big infection, it's blown a hole in the integrity of the aortic valve and the valve is regurgitating. Chronically, it will be rheumatic heart disease or connective tissue disorders, or you could be born with some congenital malformation of the valve or the things the valve attached to, or the papillary muscles or the chorda tendini, anything structurally sound. The history acutely, because remember this is aortic regurg, so it's permitting retrograde flow. So blood is not going into the aorta and staying there, it's dropping back into the left ventricle. Now what will that do? It will increase the amount of blood that is in the left ventricle, which will back up the system, and it backs it up from aorta into left ventricle, into left atrium, into your pulmonary system. So you get acute cardiogenic pulmonary edema. So they have the bibasal crackles, shorter breath, all the stuff that you would associate with pulmonary edema. But the chronic patient has left and right-sided heart failure eventually, as you get left-sided issues going on and that hypertrophy and dilation therefore, and then you get pulmonary hypertension that wrecks the right side of the heart. So you get peripheral edema as well as pulmonary edema. So there's lots of different signs for aortic regurgitation, and I've chosen 3. One is Demusset sign, which is nodding with each beat. That's a classic sign of aortic regurgitation. Another one is collapsing pulse, which you've done in the OSCEs. So you lift the hand. If you ask any pain in the shoulder, kind of lift your hand, up it goes, and you feel the radial or the brachial, and you will feel the pulse drain away as you raise the arm. And then Quincke's pulse, if you can see here, the nail bed is flashing because that regurgitation that is going out to the aorta and then it's being pulled back into the heart. So it's not being able to keep its perfusion, it's dropping back down. And that's the cause of all three of these signs. So, what will you see on examination? Well, it will be a high pitch, and pitch is related to velocity, so it's a very fast-moving, early diastolic murmur. And you might hear an S3 sound, which is the overfilling of the regurgitation, dropping your cardiac output into a cardiac input, basically. It looks like this. So it's an early diastolic murmur and it quickly fades away. And it sounds like this. So it's connected to dub, that S2. So lub dub, lub dub, lub dub, lub dub. So it's basically a prolongation because it's early diastolic of that dub. You can hear it. And that is your aortic regurgitation classically. The same triad is ECG, echo, and chest x-ray. ECG, for the obvious reasons, chest x-ray for that cardiogenic pulmonary edema and your cardiomegaly, and echo again is diagnostic. You will see the blowing aortic valve and you will see the retrograde flow. So your management is acutely, you need to fix the valve because they're in pulmonary edema, they can't perfuse their organs properly because everything's backing up. And chronically, if it's not too symptomatic, you can get away with ACE inhibitors and beta blockers. But again, this is a defective valve and no medication is going to fix that currently. We need surgeons, ultimately. That's nice tea. So, mitral stenosis, we are getting there. So, mitral stenosis, middle age. So I put a midlife crisis guy. I'm not sure what this bird is doing here. And I'm not sure why someone's taken a bite of the surfboard. Maybe it's a shark, I don't know. But anyway, so mitral stenosis commonly occurs in people of middle ages. Little bacteria floating around here because it's your group A strep, it's rheumatic heart disease that tends to cause mitral stenosis. And I think it's about 90% of cases, maybe even more. These patients will have, because it's mitral stenosis, so the left atrium during diastole cannot drain enough blood into the left ventricle. So you get backflow into the lungs again, right? So left atrium overfill and dilation, pulmonary edema, which backs up to form cor pulmonale, which is where the pulmonary hypertension is so great that it damages the right side of the heart and puts the right side of the heart into right-sided heart failure. So what will you see on exam? Well, mitral stenosis, just word association, is married to atrial fibrillation. And I don't think many people understand why. I'm trying to remember it as because the left atrium is dilated and damaged, that damages the fibers of the atrium, so it causes atrial fibrillation. Whether that's true or not, it helps me remember that AF is associated with mitral stenosis, so you need to look for AF. You need to keep the INRs at the appropriate level. You need to treat rate, rhythm, and then CHA2DS2-VASc score for thromboembolic risks in these patients. They will have pulmonary edema quite regularly, and because their left ventricle is not filling sufficiently, they'll have a low volume pulse because cardiac output will be down. So, what you'll hear is an S1 opening click. Okay, so the very start you'll hear a click, which kind of makes the S1 sound a bit louder. And this is very, very like pathognomic of mitral stenosis. And you can think of it as an increased amount of force required to open that stenosed, calcified or damaged valve. So you're pushing, like you're trying to really get a door to close that's stuck and then it slams really loudly. That's your S1 click. And then you won't hear anything until diastole, and it's mid-diastole, basically. So it looks like this, so nothing and then a little bit, and it sounds like this. And it's mid-diastolic because it's not connected to S2. So remember the last one was connected to S2. It was like lub-dub, lub-dub. It's actually lub-dub sound. That's mid-diastolic. So, the exact same triad. ECG, echo, chest x-ray. Your echo is diagnostic. For mitral stenosis, you need to treat the symptoms. originally and treat AF. So your classic is your beta blockers to decrease cardiac work so you're not racing it into heart failure, and diuretics so you're getting the fluid down. But again, damaged hearts. So valvular intervention, replacing it, doing a bit of balloon valvuloplasty to open it up in the interim is what is really needed. But remember, with mitral stenosis, don't forget AF. So, mitral regurgitation is a bit of a different kettle of fish, really. The etiology of mitral regurgitation is it can be rheumatic fever, and i.e. it could be trauma, which makes sense. If you get stabbed in the mitral valve, it could cause regurgitation. But the one you really need to think about if you're thinking about mitral regurg is papillary muscle rupture, particularly if it's really acute. So acutely, these patients will be regurgitating blood from the left ventricle back into the left atrium. So you will get acute pulmonary hypertension, you get acute cardiogenic pulmonary edema. And this patient will very quickly be hypoperfusing, the heart will not be doing well enough, and it's likely to be very badly damaged to be in this state. They will then go into cardiogenic shock. So think about how you use your exam findings to differentiate between hypovolemic, cardiogenic, neural, and septic or distributive shock. Chronically, the patient presents as SAD, syncope, angina, and dyspnea, and they'll have a displaced apex beat because of overfill. So, yeah, the key thing in the exam is to differentiate your types of shock, to listen to the lung bases for those crackles bibasally if it's acute cardiogenic pulmonary edema, to ask the heart failure questions if it's chronic, to ask about syncope, angina, and exertional dyspnea, and to feel if that apex has shifted. So, mitral regurgitation, you'll hear an S3 sound, which is dilation because of overfill, and you'll hear a blowing pansystolic murmur. So pansystolic means it's throughout systole, and blowing means it's just a whoosh noise. It looks like this. Okay, it's a really loud whoosh between S1 and 2 because what you're hearing is blood shooting back into the left atrium and the aorta. So it's just going whoosh from the left ventricle. So all of systole is just two big holes and out goes the blood. It sounds like this. You can't hear S1 and 2, you just hear a blow. And that's the blowing noise. So, ECG, echo, and chest x-ray as per diagnostic. Superb. Yeah? The management, acute, surgery. Get them in surgery. This surgery for acute mitral regurg has 50% mortality. Chronically, you need to make sure that INR is down because of risk of, obviously, the blood's not going where it should be. It's sloshing around in the heart, so microembolic events. ACE inhibitors and beta blockers, but yet again, there is no definitive medical treatment for valvular heart disease. Now, I want to really quickly mention right-sided disease because it's much rarer and much less likely to be on your exam. So, tricuspid and pulmonary Regurg and stenosis. Now, the epidemiology of tricuspid regurg is 50 to 70% of people have subclinical. So half the people watching this video have subclinical, very minor, will probably never affect you in your life, tricuspid regurgitation. It's usually a physiological thing, it's just the tricuspid valve isn't that great sometimes, but it can also be associated with heart failure. The patients will have nothing in most cases because it's so common, but they could have fatigue and a bit of edema and a bit of dyspnea. And think about what this is. So this is tricuspid regurg. So your right atrium is trying to pump into the right ventricle, which is fine, but the RV tries to pump into the pulmonary circulation, but because the tricuspid valve blows open, it goes back into the right atrium and then backs up your venous circulation and you get edema as a consequence. Because it's a regurgitation sound at the atrioventricular valves, you get a pansystolic sound. It's the same triad for investigations, ECG, echo, and chest x-ray. And the management is usually treat the cause, treat the heart failure, treat the acute rheumatic fever, replace the valve if need be. Stenosis is usually a patient who is middle-aged with a history of acute rheumatic fever, as is most stenosis if in doubt. Etiology is your group A strep. They'll have similar signs in tricuspid stenosis because, again, you're not getting enough blood back into the pulmonary system to make it useful, to make it oxygenated. So the blood is staying in the atrium or backing up to cause that edema. You get a low frequency diastolic sound because it's in the right side of the heart, it's a venous return, so it's a slower tempo. Remember we said that frequency is related to tempo, so it's just quieter as it drips in, and it will be dripping in during diastole because it's related to the atria. It's the same triad of ECG, echo, and chest x-ray, and you're going to basically do vasodilators to give you a bit of time, and then move on to surgery. Now, pulmonary regurg is commonly seen in your heart failure patients. Its cause is almost always cor pulmonale, so your pulmonary arteries are undergoing pulmonary hypertension, they dilate, and this pulls the pulmonary leaflets open to give you a sort of functional pulmonary regurgitation. The heart failure patients, you'll have heart failure signs of right and left side usually. And the diastolic right ventricular heave you might see because of the filling. The exact same stuff. It's triad and manage heart failure. Okay, so ECG, echo, chest x-ray, and manage the heart failure. Pulmonary stenosis is almost always congenital. So the cause is congenital idiopathic. And because it's pulmonary stenosis, it's exactly like the tricuspid problems. You can't oxygenate your blood sufficiently, so you get fatigue, you get dyspnea, you get edema because of the backup. Because it is the outflow of the semilunar system, right, you get an ejection systolic murmur because it's trying to eject during systole. You do the triad, and for pulmonary stenosis you need to take a balloon and blow it open and potentially replace the valve. So, a quick review of the things you need to know. In early systole, you will most likely hear a ventricular septal defect, which makes sense, right? So if there's a hole in the interventricular septum and you blow your blood from your left and right ventricle, at the very beginning it's going to go through that hole proximally before it hits the aortic or pulmonary valves. You'll also hear AV valve regurgitation. For ejection systole, it's the semilunar valve stenosis, so it's your aortic and your pulmonary stenosis. But you'll also hear it in pregnant people who have the high volume of pregnancy, as well as fever and atrial septal defects as well. So the ejection systolic is not necessarily a bad thing. Now your pansystolic throughout all of systole, that's also called hollow systolic. Your ventricular septal defect you'll hear throughout, and you'll hear the regurg throughout. Remember that massive mitral regurgitation blowing sound. And I don't know why I put ventricular septal defects twice, never mind. So, early diastolic, you'll hear the semilunar regurgitation as it drops back in at the end of systole into the ventricles. Mid-diastolic, you hear atrioventricular stenosis as the blood is getting through the that orifice from the atria to the ventricles. So that's quite an important thing, so make sure you memorise that table. Now, the final things we're going to do before we move to review is assessing a murmur and grading a murmur. So assessing a murmur, there's a subjective way that we do this, which is site, character, radiation, intensity, pitch, and timing. So if you're in an OSCE and they play a murmur to you whilst you're doing the cardiovascular exam, they'll say, describe this murmur to me. Okay? And so you need to use an algorithm that's standardized like this so you can work your way through it. So for example, site, right parasternal border. That's where I'm hearing it. The character is a blowing murmur. The radiation is to the apex. The intensity is a 3. Now we're going to talk about grading a murmur as intensity soon, so don't worry about that. The pitch is a high pitch, which means it's high velocity. And the timing is pansystolic. That's louder with inspiration. So pause the video. What is it? The answer is aortic regurgitation. And so I have described a murmur without you listening to it, and you can figure out what it is if you follow the video so far. Now, grading a murmur, if we begin with 1, it's basically nothing to hear. 2 is pretty quiet, but it's audible, so you can just about hear a murmur. 3 is it's a really simple murmur to hear, like a blowing pan-systolic mitral regurg that you can hear. 4 is when you're starting to feel the murmur, so it's really loud, this murmur now. 5 is when you can put the stethoscope on its side next to where you could hear the murmur, and then if you put your earpieces in, you can still hear the murmur. And 6 is when the murmur is so loud that you can hear it off the chest. So there's no stethoscope required to hear the murmur. So we tend to say that 3 to 6 is the danger zone. So as soon as you can easily hear a murmur, right the way down to feeling it, steth on its side, no stethoscope, these are becoming dangerous murmurs. These are a problem. Now you might have noticed that my grading animation I just did came from Boris's COVID alert levels, which we all know now came from him ripping off Nando's spice ratings. So share and share alike is what I say. Now then, this is Walsgrave Hospital in the 20s, I think, which means it's time for some patient questions. So, Irene is a 72-year-old female who rings her GP complaining of shortness of breath. Due to the pandemic, the GP arranges a face-to-face. She's rapid tested and found to be negative for SARS-CoV-2, but during auscultation, an ejection systolic murmur is heard while examining for a carotid bruit. So, after listening to all the heart valves, the GP remains uncertain about the source of the murmur. What is the next best step? On echo, the patient is found to have mild valvular disease. What is the first line management? And which of the below schema best represent Irene's murmur? So have a think what you think is going on there. All of the answers are found within the video. George, a recently retired 66-year-old male surgeon, is rushed to A&E with ischemic chest pain. Notable is elevated troponin IT, CKMB and ST elevation in leads 2 and 3. He's increasingly breathless whilst his internal jugular vein becomes raised with bilateral basal crackles of the lungs. Which artery requires PPCI? What urgent bedside investigation is required in this patient to diagnose the cause of his breathlessness? And how would you conservatively manage George as vascular surgery preps to receive him? The third case is Hassan, a 9-year-old male under the care of MSF in a refugee camp in northern Syria, with significant frontal headache last week, a runny nose, sore throat for the last month that seems to be getting worse. What's the first line investigation you order in this patient? And then the result of gas titer is positive. What is the best management of this patient? Hassan is settled and granted refugee status, then citizenship in the UK. He's followed up in cardiology 25 years later with pain in his hips and odd bumps along his arm. Describes 6 features of the most common murmur you would expect. So tell me the murmur and tell me the 6 most common features. And the fourth case is Sharon, who's 26. She presents to ED with generalized weakness and fever. History is notable for self-injecting opiates. She calls them a white horse. So given the best match differential, why use an ophthalmoscope? The pathology lab asks for your leading suspect organism to test for. Which do you choose? And the patient has a severe congenital aortic stenosis as a child and had SAVR. How would you treat this patient? And that's all I've got.